Welcome back to the deep dive. We are doing something very specific today, something that feels a bit like stepping into a pressure cooker.
It certainly does.
Usually, we take a wide-angle lens to our topics, but today, we are zooming right in, like microscope slide level. We're simulating a high-stakes scenario that a very specific, very dedicated slice of our audience knows all too well.
That's right. We are going back to school. But not just any school. We are stepping into the shoes of a postgraduate medical resident, preparing for the Doctor of Medicine, the MD exams in anesthesiology.
Specifically, we're looking at the Gujarat University pattern, which is, well, it's known for being incredibly rigorous.
It is.
The scenario is this. I am the student. I've been studying all night. I'm running on caffeine, which is ironically appropriate for today's topic, and pure anxiety.
And you.
I am the senior MD anesthesia faculty.
And you've got the clipboard?
And I am holding the clipboard. I am conducting your viva voce, the oral examination. My job today isn't just to teach you, it's to grill you. I want to see if you are safe to practice.
And we are going to tackle a topic that feels like it belongs in a medical history museum, but is actually a minefield for examinees. Theophylline and Etophylline.
The methylxanthines. Now, before we start the role play properly, Professor, I have to ask, why are we doing a deep dive on drugs that most modern protocols have, pushed to the back of the shelf? I mean, isn't this like studying how to use a telegraph in the age of the smartphone?
That is a fair question,
Yeah.
a very fair question. But it sort of misses the point of the exam. Yes, clinically we have cleaner drugs now. We have selective beta agonists for asthma. Of course we do.
Right.
But theophylline is an exam favorite, precisely because it is what we call a dirty drug.
Dirty meaning it doesn't stay in its lane.
Exactly. It goes everywhere. It hits the lungs, sure, that's what we want. But it also hits the heart, the brain, the kidneys, and the gut. It interacts with your anesthetic gases, your muscle relaxants, the antibiotics the patient might be on.
Okay, I see.
And most importantly, it has a narrow therapeutic index. The difference between a therapeutic dose and a toxic one. The dose that causes a seizure is tiny.
So the examiners love it because it tests whether you can handle a dangerous tool safely.
Precisely. It's a test of your fundamental pharmacology knowledge. If you can manage a patient on theophylline without causing a disaster,
You can manage almost anything.
you can manage almost anything. Plus, and this is important, in resource-limited settings and, let's be honest, in many government hospitals in India and elsewhere, these drugs are still the workhorses because they are cheap. You will see them.
So I have to respect them.
You absolutely have to respect them.
Okay, so my mission today is to take this dense pharmacological data from sources like Katie Tripathi, Miller's Anesthesia, and Morgan and Mikhail, and synthesize it all into a structured 20-mark answer that will get me a distinction.
And to survive the Viva traps I'm going to set for you,
Oh, great.
I'm going to ask you questions that are designed to make you fail if you aren't paying close attention.
I'm ready, I think. Let's assume I've drawn the long question. Pharmacology of theophylline and anesthetic implications. How do I begin? Where do I start?
Okay. First, take a breath. You need to frame the introduction with authority. Don't just list facts. You need to tell a story about the class of drugs. So it's Section 1, Introduction and Exam Framing. You must define the methylxanthines.
Okay.
Anchor the examiner in reality by mentioning the 3 naturally occurring alkaloids in this family. Do you know them?
That would be caffeine, theophylline, and theobromine.
Correct. And there's a nice little mnemonic or, well, a parallel there. Caffeine is in coffee. Theophylline is found in tea. Thea is the genus for tea plants. And theobromine
Cocoa, chocolate.
in cocoa. So you see, we've been using these for a very, very long time.
So effectively, humanity has been medicating itself with methylxanthines for centuries to stay awake and breathe easier.
We have. They are the oldest respiratory stimulants and bronchodilators we have. But for your introduction, you must pivot immediately to current relevance. Acknowledge they are third-line drugs for asthma and COPD, but emphasize why they are still on the syllabus.
Because of that narrow therapeutic index and all the interactions.
And specific niche uses, apnoea of prematurity in neonates, for example, or the patient with COPD who just isn't responding to anything else. If you mention refractory COPD and safety profile in your first paragraph, the examiner knows you understand the clinical landscape, not just the textbook.
So I'm signaling that I get the big picture.
You are, and you must explicitly state that while their use is declining, the risk to the patient remains high if the anesthesiologist ignores them. It's not about you prescribing it, it's about you managing the patient who walks into your theater already taking it.
Got it. Okay, that makes sense.
Right. Now let's get into the chemistry. Section 2. Chemical classification. This feels like the part where students gloss over the details, but I assure you the chemical structure dictates the clinical practice here. It's not just trivia.
Okay, theophylline is, let me check my notes, 1003-dimethyloxanthine.
Correct. And for comparison, caffeine is 1003-7-trimethylanthine. That extramethyl group makes a big difference. But let's focus on theophylline. Here is the fundamental problem. Pure anhydrous theophylline is a stubborn molecule. It hates water.
It's poorly water-soluble.
Very poorly, which is a massive problem if I need to inject it into a patient's vein during an emergency. I can't inject a suspension of powder, can I?
No, absolutely not.
Huge problem. So historically, pharmacists had to find a way to make it soluble. They did this by creating a complex salt. And this is where aminophylline enters the picture. You need to explain what aminophylline actually is.
Aminophylline isn't a different drug then. It's just a delivery vehicle for theophylline.
Think of it as a package deal, a partnership. Aminophylline is theophylline combined with ethyleneamine. It's about 85% theophylline by weight. The ethyleneamine acts as a solvent. It's what makes the theophylline dissolve in water. But there's a catch, a big one.
Ethyleneamine isn't inert, is it? I have a feeling it's not.
Far from it. It is highly alkaline. It has a very, very high pH.
I see where this is going. If it's alkaline, it's going to be irritating to tissues.
Irritating is putting it mildly. If you inject aminophylline intramuscularly into the muscle, it causes severe pain, chemical inflammation, and potentially necrosis, sloughing of the tissue. It basically causes a chemical burn from the inside out.
So this is Vivatrap number 1, a classic.
The absolute classic. If I hand you an ampoule of aminophylline in the exam and ask, "Doctor, your patient is wheezing, you can't get an IV line, can you give this IM?" and you hesitate or say yes.
I've failed the station.
You have very likely failed that station. The answer is an immediate, emphatic no, sir. It is for slow IV infusion only, and you should even mention why, because of the high pH and the risk of tissue necrosis.
Okay, crystal clear. So if aminophylline is the dangerous alkaline salt, where does etophylline fit in? Because the prompt specifically mentions etophylline, and it's in the title of our deep dive.
Etophylline is the clever solution to the aminophylline problem. Look at the chemistry. Etophylline is hydroxyethyl theophylline. It is not a salt complex like aminophylline. It's a true chemical derivative. They've actually modified the molecule itself.
And that one modification changes the solubility rules.
Completely. It becomes water-soluble on its own. But, and this is the key, it is neutral in reaction. It has a physiological pH. It doesn't burn. It doesn't irritate.
I can give etophylline intramuscularly.
You can. Oral, IV, IM. It's versatile. That is why it is the star of this chemical section. In a small clinic, a peripheral hospital without reliable IV access, etophylline is your go-to injectable bronchodilator. It has about 80% of the efficacy of theophylline, but the safety profile regarding administration is just vastly superior.
That's a really clear distinction.
Yeah.
Aminophylline equals IV only and high pH. Etophylline equals versatile and neutral pH.
Correct. And often you will see them combined. The brand name Diaphragmatic, which is famous in India, is actually a combination of etophylline and theophylline.
Oh, I didn't know that.
The idea is to get the rapid action of etophylline with the sustained effect of theophylline, a sort of best of both worlds approach.
Okay, let's move to the engine room. Section 3. Mechanism of action. This is labeled very high yield.
It is. This is where you score the bulk of your marks. And you need to be careful. Most students just say it blocks phosphodiesterase and then stop. That's a 5-mark answer. For 20 marks, you need what I call the triple threat. Katie Tripathi and Miller describe 3 distinct cellular actions. You need to articulate all 3.
Okay, let's break them down. The first one is the classic phosphodiesterase, or PDE, inhibition.
Right. Let's unpack the pathway, step by step. Inside the bronchial smooth muscle cell, you have ATP. An enzyme called adenyl cyclase gets stimulated, say, by a beta agonist, and it turns ATP into cyclic AMP, or KAMP.
And KMP is the good guy here, right? It tells the muscle to relax.
KMP is the signal for relaxation. It's the key messenger for bronchodilation, so more KMP equals more open airways.
Got it.
But there's a cleanup crew, an enzyme called phosphodiesterase, specifically the PDE4 isoform in the lungs and inflammatory cells, comes along and gobbles up the KMP, turning it into inactive 5-AMP.
So normally the body naturally limits how long the airways stay dilated. It's a self-regulating system.
Correct. Now, where does theophylline come in? It inhibits the PDE. It handcuffs the cleanup crew.
So KMP hangs around for longer.
Exactly. The levels of KMP accumulate, they stay high, and the bronchi stay dilated for longer. It's a potent effect.
And you said this also happens in inflammatory cells.
Yes. High CMP levels in inflammatory cells like mast cells and eosinophils stabilize them. It prevents them from degranulating and releasing their payload of histamine and leukotrienes, so you get a mild anti-inflammatory effect as well. It's not as powerful as a steroid, but it's there.
Okay, so that's mechanism 1. But you said there's a mechanism that specifically scares anesthesiologists.
Mechanism 2. Adenosine receptor antagonism. This is the big one for us. This is where the toxicity really comes from.
Adenosine. That's usually an inhibitory signal, right?
Yeah.
Slows down the heart, makes you sleepy. It's the brain's way of saying, I'm tired.
Exactly. Adenosine is the body's natural brake pedal. It causes bronchoconstriction. It causes CNS depression. Theophylline looks chemically very similar to adenosine. It's a structural analog. So it fits neatly into the adenosine receptors A1 and A2, but doesn't activate them. It just sits there. It blocks them.
So it's not just pressing the accelerator with a KMP, it's also cutting the brake lines.
Yes, cutting the brake lines. That's the perfect analogy. This contributes to bronchodilation, yes. But think about the systemic effects. If you block the brain's sleep signal, what happens?
You get alert, stimulated, anxious, jittery.
And if you block the heart's slow down signal...
Tachycardia, the heart races, palpitations.
Exactly. And this is the crucial Viva point you must remember. When a patient has theophylline toxicity and they start having seizures, it is not because of the CAMP mechanism, it is because of the adenosine blockade. It is essentially unchecked excitatory electrical activity in the brain.
That is a vital distinction. Seizures come from the adenosine mechanism.
Oh, got it.
Okay, what about the third mechanism?
The third one is a bit more subtle, but very important for its specific group of patients. It's calcium translocation. This is specific to skeletal muscle. Theophylline promotes the release of calcium from the sarcoplasmic reticulum inside the muscle cell.
Why do we care about skeletal muscle? I thought we were treating the lungs.
What is the most important pump in the entire respiratory system? It's not the lung tissue itself, it's the muscle that's driving it.
The diaphragm, of course.
The diaphragm. In a patient with severe COPD, the diaphragm is flattened, it's tired, it's working against immense resistance, it's in a state of chronic fatigue.
Right, the pump is failing.
The pump is failing. Theophylline acts like a shot of adrenaline, specifically for the diaphragm. It increases the force of contraction by making more calcium available. This is why a COPD patient might say, "Doctor, I feel like I can breathe better," even if their spirometry numbers haven't changed that much. Their pump is simply working stronger.
That is a fascinating nuance. It treats the failure of the muscle, not just the constriction of the airway.
Harrison's Principles of Internal Medicine highlights this heavily. It's the main reason we still find it useful in COPD, where muscle fatigue is a huge part of the problem.
I think I saw something about a fourth mechanism in the notes, something about Histone Diacetylase.
You are reading the updates. That gets you bonus points in the exam for sure.
Yes.
In some patients with very severe COPD or asthma, their lungs become resistant to steroids. The anti-inflammatory genes are essentially switched off.
So the steroids just stop working?
They stop working. Theophylline, at very low sub-bronchodilator doses, activates an enzyme called histone deacetylase HDAC.
What does that do?
It essentially unlocks the DNA, it remodels the chromatin, and restores the sensitivity of the lung to corticosteroids. It makes the steroids work again. It's a steroid-sparing or steroid-sensitizing effect. If you put that in your exam paper, you are looking at a distinction.
Wow, okay. That's a lot more complex than I thought. So, let's move to section 4. Pharmacokinetics. This seems to be where all the safety issues really come in.
This is the exam core. If you don't understand the kinetics, you cannot use this drug safely. It is well absorbed orally, but 90% of it is metabolized in the liver by a very specific enzyme, CYP1A2.
CYP1A2. That sounds like an interaction nightmare waiting to happen.
It is. It interacts with dozens of common drugs. But before we even get to the interactions, we need to talk about the kinetics themselves. This is the zero-order trap.
Okay, so normal drugs follow first-order kinetics, right? The more you give, the more the body eliminates. A constant percentage.
Usually, yes. And at therapeutic doses, say below 20 millicg/ml, theophylline is first order. But the metabolic enzymes, those little CYP1A2 workers in the liver, are saturable. They get overwhelmed. Once you hit the upper limit of the therapeutic range, the enzymes are at maximum capacity.
So the metabolism switches from a percentage-based system to a fixed amount system. Zero-order kinetics.
Exactly. It means a constant amount is eliminated per hour, not a percentage. Imagine a toll booth with only 2 lanes that can only let 10 cars through per minute. If you suddenly send 1,000 cars down the motorway, you don't get 10% through. You still only get 10 cars per minute. The traffic jam, The plasma concentration spikes disproportionately.
And since the therapeutic index is so narrow,
You jump straight into toxicity. The safe range is 10 to 20 micrograms per milliliter. A small dose increase that might take a patient from 15 to 18 could, if it saturates the enzymes, take the next patient from 18 straight up to 30. And at 30, you are well into the danger zone.
what affects the clearance? This is usually a big Viva question, right? What factors?
Always, you need to know what speeds it up and what slows it down. Let's start with what increases clearance, meaning you'd need a higher dose.
Smoking, I remember reading that.
Yes. Smoking is a potent inducer of CYP1A2. Katie Tripathy says the clearance is increased by a factor of 1.6. So a smoker needs a much higher dose of theophylline to get the same effect because their liver is just chewing it up and spitting it out so fast.
Other inducers, drugs like phenytoin or rifampicin, and children metabolize it faster too.
Correct. Now, what decreases clearance? This is the dangerous side. This is where toxicity happens.
Or liver failure, obviously.
Yeah.
If the factory's broken. And I think congestive heart failure.
CHF is a big one. The reduced blood flow to the liver slows everything down. Also, acute viral illnesses like pneumonia and simply being elderly. An elderly patient with CHF and a chest infection has an almost non-existent ability to clear theophylline. You must reduce the dose significantly.
And then there are the drugs that actively inhibit the enzyme.
The big three inhibitors you absolutely must list for the exam are erythromycin, ciprofloxacin, and cimetidine.
There was that classic scenario in the notes. A COPD patient on chronic theophylline gets a chest infection, is prescribed erythromycin, and comes back to the hospital seizing.
A textbook case. The erythromycin inhibited the CYP1A2. The theophylline levels spiked into the toxic range because of the switch to zero-order kinetics, and the adenosine antagonism in the brain caused a seizure. You have to be able to explain that entire chain of events from prescription to seizure.
That brings us nicely to pharmacodynamics in Section 5. We've touched on this, but let's break it down by a system for the exam paper, a systematic approach.
Good idea. Systematic answers get high marks. Use headings. So first, respiratory system.
Okay, we've covered this. Bronchodilation from the PDE inhibition, improved mucociliary clearance, and that really important one, increased diaphragmatic contractility.
Perfect. Next, cardiovascular system. What happens to the heart?
It's a stimulant, so positive inotropic and chronotropic effects. That means increased heart rate and increased force of contraction.
Correct. It can also cause transient coronary vasodilation, but the dominant effect is stimulation. Next, CNS effects.
Cortical arousal. It defers fatigue, keeps you awake, like caffeine. But at high levels, it's nervousness, tremors, and then frank convulsions. And finally, the kidney. Mild diuretic effect. I think it inhibits tubular reabsorption of sodium. So increased urine output. It's a side effect, not a therapeutic use. Very good. You've structured that well. Now, Section 6, clinical uses. High yield. Where do we actually use this drug today?
Okay, so bronchial asthma. It's now a third-line drug, right? After inhaled beta agonists and steroids. Used for maintenance in severe cases, or maybe for nocturnal asthma because of the sustained release preparation.
Correct. And what about COPD?
It's actually more relevant here than in asthma because of that diaphragmatic strengthening effect we talked about. It helps with the muscle fatigue component.
Good. What else?
Apnoea of prematurity. Premature babies have immature respiratory centers in their brainstem. So theophylline, or more commonly caffeine citrate now because it's safer, stimulates that medullary respiratory center. It literally reminds the baby to breathe.
An excellent point. And one more slightly obscure one from Miller's anesthesia.
Post-dural puncture headache, or PDPH.
And why would that work? Because methylxanthines cause cerebral vasoconstriction. Since PDPH is thought to involve vasodilation and intracranial sag, theophylline can theoretically help. But you usually just give the patient a cup of strong coffee.
You would, but it shows you've read beyond the basics.
Good. Now let's talk specifically about etophylline again in Section 7. Why would an examiner ask about this separately from theophylline?
Because of the practical advantages. It's about what you do in a real-world clinic, not just the pharmacology.
Exactly. What are those advantages?
First, solubility. It allows for concentrated parenteral forms that can be given IM, which is a huge deal if you can't get a vein. Second, the mixing issue. Explain that. Aminophylline has a high pH. It's alkaline. So if you try to mix it in the same syringe with an acidic drug like, say, adrenaline or certain antibiotics, it will precipitate. It'll turn cloudy. You can't inject that.
Right.
But etophylline is neutral, so you can mix it. That's a huge practical advantage in a resuscitation or an emergency.
It is. And the third advantage, The notes say Etophylline has reduced CNS toxicity compared to pure Theophylline. Katie Tripathi mentions it has slightly less CNS penetration, so it's a bit safer when it comes to the risk of seizures. Still have to be careful, but it's a bit safer.
Very good. You've covered the key examiner-oriented points. Now for the section everyone dreads. Section 8, Adverse Effects and Toxicity. This is absolutely essential.
You have to know this inside and out.
You do. You need to correlate the toxicity with the plasma levels. So at greater than 20 micrograms per ml, what are the early signs?
The GI symptoms kick in first. Nausea, vomiting, dyspepsia, that kind of thing.
And is that vomiting just because it irritates the stomach lining?
No, it's a double whammy, isn't it? It's local irritation, but it also directly stimulates the CTZ, the chemoreceptor trigger zone in the brainstem. So it's a central effect as well as a local one. You also get headache and insomnia.
Good distinction. Now, what about when the levels creep up higher, say, greater than 40?
That's when you start seeing the cardiovascular and CNS effects. Sinus tachycardia, tremors, agitation, restlessness. The patient is jittery and their heart is racing.
And at greater than 60, the severe end of the spectrum.
This is life-threatening. Severe toxicity. You get seizures, which can be focal or generalized, and life-threatening arrhythmias. The arrhythmias are usually ventricular, VF or VT. Okay. And you can get severe hypotension from that.
Right. And there is a very important warning here in the notes. Seizures can occur without preceding nausea. Why is that?
That's the acute overdose pattern. Yeah. If someone swallows a whole bottle of tablets, the plasma levels spike so fast they hit the CNS toxicity threshold before the gut has time to react. The brain effects can happen first.
So the key lesson is?
Do not wait for vomiting to diagnose a serious overdose. A patient can be seizing without ever having felt nauseous.
Excellent. Now, Section 9, drug interactions. We talked about the enzyme inhibitors, but what about interactions with our drugs, with anesthetic agents? This is the anesthetist's nightmare part of the syllabus.
Okay, this is high yield for the paper.
It's extremely high yield. Number 1, halothane.
Right. Halothane sensitizes the myocardium to catecholamines. Theophylline increases catecholamine release and also directly stimulates the heart. So you put them together.
And what's the equation? Halothane plus theophylline equals?
Severe ventricular arrhythmias, a recipe for disaster.
So as a rule, you avoid halothane in a patient on theophylline. Use sevoflurane or isoflurane, which are much safer.
Got it. What's next?
Number 2, neuromuscular blockers, specifically the non-depolarizing ones like pancuronium or vecuronium.
Theophylline can antagonize the block, right?
Yeah.
I think it increases acetylcholine release at the neuromuscular junction, so you might find your muscle relaxant isn't working as well or it seems to wear off too fast.
Correct. You may need higher doses of your relaxant. Number 3, benzodiazepines.
This goes back to the adenosine blockade. Adenosine is sedative, benzos are sedative. Theophylline blocks adenosine, so it antagonizes the sedative effects of the benzos.
Which means
a patient on chronic theophylline might require much higher doses of midazolam to achieve the same level of sedation. They're sort of pharmacologically resistant to it.
They are. And finally, ketamine.
That seems like a bad combination. Ketamine can lower the seizure threshold. Theophylline causes seizures. Putting them together is risky, especially in a patient with any kind of pre-existing risk for seizures.
It's a risk you have to weigh very carefully. Okay, that leads perfectly into Section 10, anesthetic implications. This is the heart of the exam question. This is where you bring it all together.
Okay, so I should structure this chronologically, right? Pre-op, intra-op, post-op.
Well, chronological structure is always best. So, preoperative assessment, what are you looking for?
First, I'm checking if we can get a blood level. If we can, I want to see it in that 10-20 millicg/ml range. I'm also assessing the patient for clinical signs of toxicity. Are they jittery? Is their resting heart rate 110? If so, we might need to postpone the surgery and optimize them first. Good. Now, the big conceptual question. Do we stop the drug before surgery?
The guidelines, like Yao and Artuzio, say you should not stop it abruptly. And why not?
Because if you stop a chronic theophylline user the night before, they might have a severe rebound bronchospasm on the table during induction. The risk of bronchospasm outweighs the risk of the drug's interactions as long as you're aware of them.
So the rule is?
Continue it until the morning of surgery, but be extra vigilant and manage your anesthetic accordingly.
Perfect. Now, intraoperative management, your choices.
Induction. I'm going to be cautious with histamine-releasing drugs, so I'd probably avoid morphine and atracurium if the airway is particularly reactive. Even though theophylline itself stabilizes mast cells, it's better to be safe.
Prudent, volatile choice.
We've covered this. Avoid halothane at all costs. Use sevoflurane or isoflurane.
Reversal of muscle relaxation.
Miller notes that the interaction with neolistigmine is minimal, but you have to watch the ECG closely. You've got two drugs affecting the heart rate in different ways, so you could see some complex arrhythmias.
And if an arrhythmia does happen intraoperatively,
I need to have my treatment ready. Lidocaine for ventricular issues or a short-acting beta blocker like esmolol. Have them drawn up and available.
one last very important point for intraop management.
Gastric acidity. Theophylline increases gastric acid secretion, so these patients are at a higher risk for aspiration.
Which means?
Aspiration prophylaxis. An H2 blocker, or a PPI, is mandatory. You have to protect the airway.
Excellent. Okay, section 11. Role in modern practice. Why is its use declining?
Because, as Harrison says, it's a dirty drug. It hits the heart, the brain, the gut, the kidneys. The newer beta agonists are much more selective. They just hit the beta-2 receptors in the lungs mostly. They're cleaner and safer.
So theophyline's niche is for?
The non-responders where that histone decetylation mechanism is useful, or in resource-limited settings where cost is the #1 factor, because it is very, very cheap.
Good. Section 12. Contraindications. When do you absolutely not use it?
Uncontrolled epilepsy is an absolute no. It lowers the seizure threshold, active peptic ulcer disease because of the acid secretion, hyperthyroidism because it will just exacerbate the tachycardia, and a recent myocardial infarction. You don't want to stimulate an ischemic heart, and it's unsafe in porphyria.
Very comprehensive. Okay, Professor. I am feeling more confident now. Hit me with section 13, the Viva traps.
Right. Let's see how you do.
Trap number 1. I ask you, doctor, your patient on Theophylline is having a seizure. How do you treat it?
I would give an IV benzodiazepine, like diazepam or lorazepam.
That's the first line answer. Correct. But the trap is not knowing what to do if that doesn't work. The real trap is that these seizures are often resistant to standard anticonvulsants.
Oh, so if diazepam fails,
you may need to move quickly to intubation, heavy sedation with propofol, and mechanical ventilation. In severe cases, the definitive treatment is removing the drug from the blood with hemoperfusion or dialysis. You have to mention that to show you understand the severity.
Okay, that's a key point. Diazepam might not be enough.
Trap number 2. I ask you, so is theophylline just a bronchodilator?
No.
Yeah.
That's a classic oversimplification. I have to emphasize the other mechanisms, the increased diaphragmatic contractility in COPD, and the anti-inflammatory histone deacetylation effects that restore steroid sensitivity.
Perfect. Trap number 3. A patient comes into the ER with theophylline toxicity. They have been vomiting constantly. Do you give them a standard antiemetic like metoclopramide?
Wait, metoclopramide. I feel like there's a problem there.
Think. What does metoclopramide do apart from stop vomiting?
It has CNS effects. It can cause extrapyramidal symptoms. Oh, it lowers the seizure threshold.
It lowers the seizure threshold. And theophylline causes seizures. It's a terrible combination. You have to be incredibly careful with your choice of supportive care drugs.
That is a sneaky one. I would not have thought of that under pressure.
That's why we do this. Forewarned is forearmed. Okay, section 14. Diagrams and exam presentation. For the 20-mark long answer, you need to draw something. What do you draw?
The cell membrane mechanism. I draw a beta receptor on the cell surface, stimulating adenyl cyclase inside, then show ATP turning into CAM-MP. Then I draw the PDE enzyme breaking CAM-P down into AMP, and then, the most important part, I draw theophylline putting a big fat X or a block sign on the PDE enzyme. I'd also show it blocking the adenosine receptor on the cell surface.
Visuals get you extra marks. It shows you truly understand the pathway. And what about a table?
A comparison table. Theophylline versus etophylline.
What are the columns?
Column 1, feature. Column 2, theophylline. Column 3, etophylline. So row 1 would be solubility, low for theo, high for eto. Row 2, IM injection, no painful for theo, safe for eto. Row 3, CNS toxicity, high for theo, lower for eto. That gives the examiner everything they need to know in a quick, easy-to-read format, a very solid answer structure.
Finally, section 15, summary and conclusion. This is your last chance to impress. Give me the mic drop conclusion for your exam paper. Sum it all up.
Okay, let me try and phrase it right. While theophyline's clinical popularity has waned due to the advent of safer, more selective beta agonists, its unique pharmacodynamic profile, particularly regarding diaphragmatic contractility and steroid sensitization, ensures it remains a valuable adjunct in refractory COPD.
Good start. Now bring it home for the anesthetist.
However, its use necessitates extreme vigilance by the anesthesiologist regarding its narrow therapeutic window, its switch to zero-order kinetics and toxicity, and its potential for life-threatening interactions, especially with enzyme inhibitors and the volatile anesthetic halothane.
Outstanding. That is a distinction-level conclusion. It's balanced, it's specific, and it's relevant to our specialty.
I feel much better about this topic now. It's not just that old asthma drug. It's a physiological multi-tool with a lot of very sharp edges.
Exactly. And now you know where those sharp edges are. Before you walk into the exam hall, visualize that PDE pathway in the zero-order kinetics graph. And remember, if they ask you about giving Aminophylline IM,
Just say no, emphatically.
just say no.
Got it. Thanks, Professor. And thanks to everyone listening to this deep dive. Hopefully your next Viva will be a breeze. Study hard and stay curious.
See you next time.